First of all, I would like to apologize because it might be a quick whiz through because both topics are quite huge, but I'll try to go through them quite quickly so we can get as much information as we can. And I suspect that we'll have a lot of questions at the end, and probably at other talks we'll be able to go into more details as well. But just to give a synopsis of what it's all about. So fibroids, and the Greek word, the medical term for fibroids is leiomyoma or leiomyomata, and it's split into, it's a Greek word combined. Leios means smooth in Greek, and myo means muscle in Greek, so smooth muscle. So it's actually made up of smooth muscles, which are sort of hard, round tumors, which a lot of people worry about because the first thing they think about is a tumor, is a cancer, but it's not cancerous. It is actually benign, it's non-cancerous. A lot of people also hear about fibroids, and what they think about is a lot of emotions come up. There's fear, they've been scared, they've heard a lot of things from their family and friends about fibroids. They're embarrassed about it, they're worried about it, and there's that fear also of subfertility. But a lot of times it really depends on the size of the fibroids. It also depends on where the fibroid is as to whether it causes problems at all. Next slide, please. So we have different types of fibroids depending on where they are in the womb. So you've got intramural fibroids, which are the most common ones. It's actually in the muscle of the wall, and they cause painful periods. And they cause painful periods because they interfere with the constriction of the blood vessels during menstruation. And depending on the size, if they're bigger than 5 centimeters, they can also cause subfertility. But most times they don't, except they're much bigger than that. And then because when they're large, they can increase the cavity of the womb and cause increased bleeding as well. You then have the subserosal ones, which are actually on the outside of the womb. If you look to the right of your slide below, so it's on the outside. Most times, these do not cause any problems at all whatsoever, but if they're huge, they could cause pressure symptoms on bowels and bladder. So that you could have symptoms like increased frequency or urgency or even diarrhea with the bowels. Then you've got pedunculated fibroids, which if you look to the right, so that could either be pedunculated subserosal or pedunculated submucosal. So if it's subserosal on the outside, it only causes problems if they're huge. So looking at the picture, I'm talking about the left side underneath. Yeah. So they would only cause problems if they twist on their stalk, so they can cause pain. So if they twist on the stalk, the blood supply to it dies, it causes pain. Otherwise, it doesn't cause any harm in terms of fertility. It doesn't increase your bleeding. It doesn't cause menstrual menorrhagia. That's heavy periods. It doesn't cause that. But it can give you pain if they're huge and they twist on the stalk. The submucosal ones are the culprit when it comes to a symptom. So it would give you increased bleeding. So your periods could be heavier. And when your periods are heavier and passing huge clots, they could also be painful. And also they could cause subfertility. So if you think about it, it's in the womb and it's like a foreign body in the womb. So if you think, when we use the coil, the whole idea of the coil was to put a foreign body in the womb and stop you from getting pregnant. So the submucosal fibroids act like that as well. So those are the ones that could cause problems with fertility. You also have the cervical one, which also causes problems during delivery when you're pregnant and to cause obstruction during delivery. Otherwise, that's cool. Next slide, please. So we'll be talking about the prevalence of fibroids. They're the most common benign uterine tumors in women of reproductive age. The incidence of fibroids actually increases with age. It starts from menarche, that's the beginning of your period, and it goes on till menopause. And it also increases in size as you get to menopause, but at menopause, it stops growing and actually shrinks from then onwards. Okay. And fibroids are more common. It cuts across all races, white, Afro-Caribbeans, Asians, and Caribbeans, but it's more common in the Black population, women. And they tend to grow earlier in your reproductive years, and also grows bigger in the Black people. Studies have shown that in a lot of women, they could have fibroids and they wouldn't even know about it. So in terms of causes of fibroids, we don't know, but we think that there might be hormonal factors. So hormones such as estrogen and progesterone are thought to contribute to the growth of fibroids, which is why you have it after you've started your menarche, so when you started having periods, and which is why at menopause it shrinks off, because at menopause your hormones go down. There's also genetic factors in that it runs in families. We know that when you have a first degree relative who's got fibroids, you have 2.5-fold chance of having fibroids yourself, and you have 6.5-folds of actually developing them earlier as well. There is also no clear reason why it's more common in Blacks. Well, excuse me if people find this offensive, but in Afro-Caribbeans, more common them than the white. We don't know why, but there seems to be more predisposition to that. There is also the environmental factors. Smokers tend to have less fibroids, but that's not a reason to smoke, because we know there are more things that smoking can cause. We also know that being overweight and eating habits could also increase your chances of having fibroids. So if you're overweight, you have 2 to 3 times risk of having fibroids. So in terms of the natural history of fibroids, it's so unpredictable. We don't know why. We don't know why it happens, but we know that it actually depends on the woman's age. We know as you get older, you probably grow more. We know that when you go through menopause, it would sort of shrink. So next slide, please. So in terms of risk factors, it's almost like I'm repeating myself, but it's just to go through it again. We know as you get older, the risk of you forming fibroids increases. We know that early menarche, so if you start your periods early, the chances of having fibroids increases with that. And the size also increases as you get older. We know that women who've never had children have more chances of having fibroids and having larger fibroids as well. So there is a saying that says if you don't grow babies, you will grow fibroids. So it's to be aware of that. We also know that high BMI, so the higher your BMI, the higher the chances of you having fibroids. We also know that if you're Africans or Afro-Caribbean, you have an increased risk of that, of having fibroids. We also know that family history increases the risk of you having fibroids. So you have a first degree relative that has it, repeating myself again, you have 2 to 3 times of having fibroids. We know the birth control. We know the women who have used the pill tend to have less fibroids. We don't know why, especially if you've used it for several years, but we don't know why, but that's what studies have shown. So in terms of symptoms, most women will have no symptoms at all, which is why sometimes you could end up having an ultrasound scan for something else completely different. You find your fibroids, and some people get fixated on these fibroids even if they have no symptoms at all. The ones that we worry about or do something about or should do something about is when it's causing symptoms. So symptoms like heavy periods. Like I said, the submucosal ones are the most common culprits, or if you have an intramural one, which increases the cavity. So if your cavity increases, your lining of the womb increases, so increases the period, so you'll have heavier periods. If your fibroids are huge, it can have abdominal swelling. I'm sure we know friends or relatives who has huge stomach, but it's actually not due to fats like most of us, but it's actually because they've got huge fibroids. And they could cause bowel symptoms, they can cause urinary symptoms, they can just be uncomfortable. If you're having heavy periods, you could also end up being anemic. Depending on the size, if they're quite huge, they can also compress, sort of tilt backwards and lie on some nerves to give you some back pain, which is not great. It can also give you painful intercourse, which is quite rare, but can be depending on the size. And also if you have a cervical fibroid, might give you painful periods as well. So the one that worries most people the most, apart from the heavy periods, is the subfertility. Like I said previously, it's usually submucosal fibroids that causes subfertility, or intramural fibroids when they're bigger than 5 centimeters. Otherwise, unlikely. So I know a lot of people get asphyxiated if they've got problems with subfertility. They get fixated on the 2 centimeter fibroids, which might be outside the womb, thinking that's the reason for their subfertility, but it's usually not. But it's a good idea to keep an eye on things. Thank you. Next, please. So in terms of investigation, when you go, when you see your GP or your doctor, what they tend to do is take a good history as to decide whether you might have fibroids or not, and what you're presenting with, and whether you're symptomatic with it or not. Invariably, you will have an abdominal examination and maybe a pelvic examination, depending on what you're complaining about. But you would definitely have an ultrasound scan to locate where these fibroids are, if you have them, where in the womb they are, and also the sizes of the fibroids. Okay. And invariably, when it comes to having an ultrasound scan, you tend to have a transvaginal scan, especially except if the fibroids are quite big and they can be seen abdominally. Depending on the size of the fibroids, or if they're planning to have any surgery, you might have an MRI scan, because if the fibroids are quite huge, you want to know if they're pressing on your ureters or pressing on any other organs. And also with the MRI is also done, because very, very, very rarely, I think less than 1% of them could become cancerous later on in life. You could also have a hysteroscopy to have, and what a hysteroscopy is actually a camera. It's done under local in most cases in the outpatient clinic, where camera is passed through the neck of the womb to look into your womb and to see whether the fibroids are indented into the cavity, so whether they're submucosal or you've got pedunculated submucosal ones, or you have endometrial polyps. Next slide, please. So treatment. So treatment of fibroids really depends on what you present with, what you're trying to achieve. So if all you're having is heavy periods, heavy painful periods, you can have non-steroidal anti-inflammatories, which could be the one that we use most commonly as gynecologists are usually mefenamic acid. But ibuprofen, naproxen, diclofenac can equally be used. We also use something called tranexamic acid. And what tranexamic acid does is actually reduce the bleeding. So the mefenamic acid, the non-steroidal anti-inflammatory, how that works is it reduces prostaglandin, which causes pain. Good, thanks. Which causes pain. And side effects of non-steroidal anti-inflammatories are acid reflux. If you're asthmatic, you can't use it. It won't be advisable. So you might have to deal with other things like Buscopan to help with the pain, or um, cocodamol or some codeine to help with the pain, or even just paracetamol. In terms of tranexamic acid, it's an anti-fibrolytic agent, and how it works is reducing your bleeding. So it stops, it increases clotting in the vessels so that you don't bleed much. If you think about it, when you have periods, what's happening is the lining of the womb sheds, so you've got the vessels open up, so it sort of constricts the vessels and cause clotting there so that you don't bleed too much. So obviously, if you have a predisposition to clotting or family history of clotting, so i.e. deep vein thrombosis or pulmonary embolism without other risk factors for it, or it's more like a genetic thing, then it would not be advisable to use this. Another treatment is using the combined pill. Why do I say combined pill? With the combined pill, you have both estrogen and progesterone. As long as you don't have any contraindications to it, the way it works, the combined pill actually reduces the thickness of the lining of the womb. So with that, you have less bleeding. With less bleeding, you have less pain. So your periods are much less and your pain is much less. You can also do cyclical progestogens as well, which are things like noethistérone, Provera, and what that does is also reduce your bleeding as well. You've also got GnRH analogs like Zoladex. That's usually used nowadays pre-operative. So if they're going to operate, sort of thinking of doing a mammectomy, so they would give you that. There's usually injections, which could be monthly or 3 monthly for about 3 months before the operation. And what that does is help shrink. It's to help shrink the womb, the fibroids, so that when they're doing the mammectomy, it doesn't bleed so much. And then you've got Esmea as well, which is quite also, it's one of the new ones as well, which also helps with the bleeding. Any concerns with side effects and things like that, you can always discuss fully with your clinician, which can be your GP or your obstetrician or your gynecologist, sorry. Next slide, please. So I wasn't going to put this on the surgical, it's sort of in between. So this is uterine artery embolization, and this started in the mid-90s, and it's sort of become very effective nowadays. When it first started, it was hit and miss, but now it's quite good. And essentially, what it's done by the radiologist, and what they do is actually pinpoint what blood supply to the fibroid, and they sort of put sort of like embolize it and stop the blood supply to the fibroid. And what it does is shrinks the fibroid, and it's actually an alternative to mammectomy. With surgical treatment, you've got mammectomy, which is usually more offered if you're still planning to have children and you're having, because it's usually easier to do a hysterectomy than to do a mammectomy. If you're having huge problems with your fibroids and you've completed your family, hysterectomy might be more advisable, but obviously it really depends on how you feel about it and your state of mind. Mammectomies can be done laparoscopically or hysteroscopically. Laparoscopically will be done more for the subserosal ones, the one on the outside of the womb that I explained earlier. That's much easier to do laparoscopically. Or you can have hysteroscopically for the submucosal one. So that's done with a keyhole through the neck of the womb. The laparoscopy is due the belly button on the outside of the womb. Hysteroscopic is through the neck of the womb to sort of do the lining of the womb. So that's usually submucosal. So if you're having problems with subfertility and the fibroids are not that big, that's done hysteroscopically. You can also have an open mammectomy, which would be a cut in the abdomen, and it's done laparotomy, through a laparotomy. You can also have endometrial ablations, and essentially what that means is it's using hot water or diathermy, and what they do is they sort of kill off the lining of the womb, and in some cases that helps as well. Sorry, any questions?
At this point, I would advise, if you do have any questions, could you please put them in the chat and we'll take them from there, or alternatively, if you want, you can just put them in the chat and we can address all the questions at the end. So it's entirely up to you. And Dr. Folakemi, it's up to you as well if you'd like to take. And by the way, you can put the questions in the chat at any point. You don't have to do it at the end. So as you're getting the information, if you do have a question, then please just put it in the chat at that point, and then we can address it all at the end, if that works for you, Dr. Folakemi.
I don't mind either. How are we doing for time? Because I think we've more or less finished fibroids. I've sort of whizzed through. My apologies. And if there are any questions, I've heard.
What I'll do then, I will go to the chat and see what questions we do have.
We can do it at the end.
We have questions. We do have some questions. Some of them you've actually answered already. So do we know why it's more common in Black people? I heard you say we don't, you know, it just is. So that's the answer to that question, I believe. Do you want to add anything on to that, Folake?
No, we don't know why it's more common at all.
Okay.
It could, I mean, it's almost like why are Blacks more tend to have sickle cell disease? We don't know.
Mm-hmm.
We know
it's one of those kind of,
It's just one of those things. There's been a lot of theories out there. Some people talk about, because of if you have a diet rich in estrogen, like eating a lot of yam, but how many people you wouldn't have to eat a lot of yam to have it affect you. I think it's more that's hormonal. Genetic, if it runs in families. So that's all I could say. Yep.
Then there was one about food. I have heard people say that the cause of fibroids may be related to the foods we eat, e.g. rice. What are your thoughts on that theory?
I haven't heard about rice being part of the theory. No.
So yeah,
not
it would be.
All.
It would be the phytoestrogenic foods more so than.
Yes, it's more of the estrogenic foods that would be more.
There was a question about side effects to drug treatments. I jumped in there because obviously I can. So I did.
You're the pharmacist. You do that.
Absolutely. So I jumped in there. So I think that's answered. And then there's a lady that's talking about Sonata treatment. She's had very bad side effects, heavy periods, lower back pain. She's awaiting Sonata treatment. Has anyone had Sonata treatment?
Sonata treatment is actually an alternative treatment. I know some hospitals are doing that now. It's more like a diagnosis, trying to do it from down below. I'll be honest, I haven't had much experience about it. So I would have to check that very, very quickly and get back to you about it.
Okay, and then the final question right here at the moment is, how do you embolize the uterine artery?
It's done by the radiologist. So they sort of look, they do a dye. So they see what arteries feed the fibroids, and then they embolize it.
Okay, let's move on.
The Sonata treatment is more like it's an ablation. So it's a name, well, so it's part of the ablation. So it's a transcervical ultrasound guided ablation of the fibroids. So, I mean, I don't know anybody that's had it. It seems to be one of the new and innovative treatment, and not all hospitals do them. But I think quite a few are doing them, and it looks like it's replacing the diathermy. It's the diathermy and also the hot water ablation that used to be done in the past, and this using radiofrequency ablation.
Can I
Someone's
ask
hand is up.
Alpa to please park your question at this point, and we'll come through with all of those, anything verbal at the end, if that's okay, just so that we can.
That's absolutely fine.
Fantastic. Thank you so much. I'll bear you in mind for number one to go when questions come through.
That's fine, no problem. Thank you.
Brilliant. Okay, please.
Okay, back to the presentation.
Thank you. So the next one is menopause. I think menopause doesn't just affect Black women, it affects all women. So it's a natural stage in life, and it's part of the aging process in women. And it marks the time when a woman's period actually stops completely because the ovaries have stopped producing eggs. Next slide, please. And we have something called perimenopausal. For some people, perimenopausal might be non-existent. For some people, it might be very long. So we don't know. The average age of menopause is 51, but before menopause, a few people will start having irregular periods, and that time when you start having irregular periods till 12 months after your last period is called perimenopausal. Menopause is 12 months of no period, then you know you're menopausal. We also have induced menopause, which is cessation of menstruation, which could be due to hysterectomy or the ovaries being removed, or ablation, or chemotherapy, or radiotherapy, or treatment with GnRH analog. Next slide, please. We also have premature menopause is when there's complete cessation of ovarian function before the age of 40. And one needs to differentiate that from premature ovarian insufficiency, because premature ovarian insufficiency is a clinical syndrome, which it could be a transient loss or permanent loss of ovarian function before 40 years. You find that some women might have no periods for about a year or 2 or 3, and then all of a sudden it starts again. So that's premature ovarian insufficiency, which could also be called premature ovarian failure, but it could be transient or permanent. That's different from premature menopause, where there's complete cessation and the ovarian failure is permanent. You have early menopause, which is having menopause between the ages of 40 and 45. Next slide, please. So we talk about menopause, and we know the main hormones produced by the ovary is actually estradiol, progesterone, testosterone. And in the premenopausal woman, the function of the ovarian function is controlled by 2 pituitary gonadotropins, which are produced from the pituitary gland in the brain, and they sort of drive the hormones in the ovaries. And it's under this that all your function, your hormones are produced, your steroid hormones are produced. So in women, when you transit from being premenopausal to menopause, it's your ovaries are beginning to stop working, and your brain is producing more FSH to sort of flog your ovaries, more or less, in lay language, sort of flog your ovaries to produce more of the estrogen, more of the progesterone, so you have high FSH. So in a woman who's postmenopausal, your FSH is high and your estradiol is low. Next slide, please. So in terms of symptoms of menopause, for those of us who've gone through menopause, we all know what most symptoms are like. The most common symptoms I think I would say more early symptoms a lot of people experience first are the hot flushes. And I remember as a young gynecologist, I never could understand it. I had absolutely very few sympathy for women who came in and said, they had hot flushes. It was like, what's the big deal? Wipe your face, open the windows. What's all the fuss about? But having experienced it from the age of about 42, where you're sitting there and it just overwhelmingly, you start sweating, you're opening the windows, everybody else is cold, you're hot, and you're causing a nightmare to everybody else around you. You know what it's like. So you get a lot of hot flushes, you get a lot of sweats, night sweats, interrupted sleep, there's weight gain. In terms of psychological effect, you feel dizzy if you don't sleep well, you're tired all the time, there's anxiety. On this slide, it says poor memory. There is poor memory, but I think a lot of people experience more of a brain fog where you just can't coordinate your thoughts together and everything seems, and you can't get them all together. So sort of brain fog, there's irritability, there's a depressive mood, there's complete loss of interest in sexual activity, you have a headache all the time, there's palpitations, your breast could become enlarged, it could become painful, it could shrink, skin is dry, it's itchy, it's thin, it's tingling. It's amazing how having your hormones sort of keeps things at bay, and when the hormones then go off, what's the symptoms you would have. So in terms of your menstruation, your menstrual cycle as well, they could become shorter, where you're having period which seems to be every week or every other week, and it could become longer, and your bleeding could be quite heavy, or your periods can become lighter, and with longer cycles, you can have bleeding in between periods, you can have joint pains, joint stiffness, urinary incontinence, urgency, painful periods, what is thought to be pain on passing urine. You'll get diagnosed with UTI all the time, but in actual fact, when they send the urine off, there's no infection in the urine, and it's actually because the bladder is also affected because there's no estrogen, there's atrophy of the bladder, so it causes what you think is UTI. You get a lot of painful burning when you pass urine. You're passing urine more often than usual. There's vaginal dryness. There's painful periods as well. Next, please. So, what can we do? In terms of treatment of menopause, well, should I say treatment? Yeah, treatment. It's a holistic, it has to be an holistic approach, and it has to be individualized depending on each person. So first things first is lifestyle. What can you do to make things better? So your diet is important. Healthy diet, very important. Reducing your alcohol intake. If you drink a lot, your hot flushes will be worse. So doing that, improving your heart as well. Because we're talking about Menopause Awareness Month. For this year is actually cardiovascular. So we know that when you go through menopause, there's increased risk of cardiovascular events as you get older. In postmenopausal, because of the estrogen, is protective when you're premenopausal, and when you're menopausal, it's gone. You don't have your estrogen, which is protective, so you end up having sort of the risk of heart attacks in men and women sort of equalizes postmenopausal. With premenopausal, there are more men than women have heart attacks. So go back to diet. So protein-rich foods, quite good for you. So fruits, vegetables, dairy products. In terms of carbohydrates, complex carbohydrates. So whole grain foods, it's also quite helpful. Also high GI foods like starchy vegetables are quite good. So mashed potatoes, jacket potatoes, grains, tapioca. It's nice to try and avoid instant foods or easy cooked foods because they're more processed foods. So trying to avoid processed food is good. Trying to avoid, choose basmati rice over other rice, or better still, if you can tolerate it, brown rice. Some people love brown rice. I'm not a fan of it. So I do basmati instead. So new potatoes instead of old potatoes. In terms of snacks, try to avoid salty snacks, sugary snacks. Do with nuts, seeds. Oat cakes are much better. And it's usually nice to combine your protein foods with your carb-rich food. So it's not just one or the other. Okay. You also do diets rich in calcium and vitamin D. That's very important. And every woman, especially Afro-Caribbean women or Asian women, should be taking vitamin D between the months of October, if you're in England, between the months of October and March, because there is no sun in England. I tend to say, if you're one of those that covers up and you use the, and you cover up more often, so you can't absorb whatever little sun we've got, then you should probably take vitamin D all year round. Regular exercise is very good. In terms of exercise, it helps you relieve stress. It helps you cope with your symptoms. It helps you cope with anxiety. And it also decreases premature death and cardiovascular disease. It reduces the risk of diabetes, hypertension, and also reduces the risk of obesity, which we know also doesn't help with your increases your cardiovascular risk. We know that exercise also increases flexibility, which helps with your joint pains, and also weight bearing activity helps with maintain your bone mass for later life. If you do smoke, do stop smoking, because it increases your risk of going through early menopause and also triggers your hot flushes as well. So women who are overweight, I can't sort of say too much. If your BMI is high, increased risk of symptoms, increased risk of cardiovascular risk, increased risk of what we talked about earlier, fibroids, increased risk of diabetes, and that's so being of average BMI would be a good idea. Alcohol, I wouldn't say zero to alcohol, because studies have shown that a little bit of red wine does help reduce your cardiovascular risk, but it's quantity. So I would say, I mean, the NICE guideline says for a woman, you shouldn't take more than 14 units a week. If you can stay below that, that's even better still. If you're having very bad hot flushes, I would say reduce your alcohol intake as well. Regular pelvic floor exercises would also help with your urinary symptoms, as well with the incontinence, urinary incontinence, and the urgency as well. For some people, relaxation techniques, we talk about meditation, yoga, CBT. Some people need a bit of CBT as well to help with their anxiety, coping with menopause. I'm just so glad that we're talking about it, and we're talking more about this. Many years ago, we never used to talk about menopause, and women just suffered in silence, and that was it. So in terms of advice on lifestyle, in terms of hot flushes, I'll just reiterate: regular exercises, weight loss when you can, have a portable fan will be helpful, turning down central heating, even at work. It's something that you can have a word with your manager to get you a table fan that you can put on your desktop to use if you need to. Try and reduce stress. I know we all live in a very stressful environment at the moment, but reducing stress does help. So exercise all the time. In terms of sleep disturbances, try and maintain a regular bedtime. Don't vary it. Try and avoid using blue light. What do I mean by that? Your phone, going to bed with your phone, try and leave your phone either switched off or avoid being on your phone while in bed. avoid watching telly while in bed. If you're watching something interesting like a movie on Netflix, there's no way you're going to sleep. You've got your hot flushes on top of watching something interesting, and then you have a bad sleep. Then that means you're even more tired in the morning, and that's not going to help. So reduce phone, reduce telly, reduce your laptops, you reduce your tablets, keep them away from your bed because they are actually our distractions. Next, please. So in terms of treatment, please forgive me if it seems as if I've jumped straight to hormone replacement therapy. Forgive me. That's the gynecologist in me. But there are alternative therapies as well. But I apologize if this slide came up first. So in terms of hormone replacement therapy, it's essentially just trying to replace what you've lost at menopause. And before I go into that, you don't have to have stopped your periods completely before you start having symptoms. You don't have to have stopped your periods completely before you can have treatment for your menopausal symptoms, so your perimenopausal symptoms. So please, I'm going to say this, if you're having symptoms, do not suffer in silence. Make sure you see your GP, do all the lifestyle changes. Do not get swapped off by saying, oh, you're still having periods, you can't have HRT, you can't have this, you can. You can. So that's very important. Like I said, I was a naive young gynecologist. I couldn't understand it when I was young, but I think there's more awareness now, not just in the menopausal community, but also amongst doctors as well. We're more aware of it, and we're more aware that women do suffer, and they suffer badly. And it's not just the physical symptoms, to also the mental health symptoms, the emotional symptoms, and they need to have support. So in terms of hormonal replacement therapy, you've got, if you've got estrogen, you've got non-estrogen, which is Tibolon. Tibolon has both estrogen and progesterone properties. You've got progestogens and you've got testosterone. If you've got a womb, you would need to have progesterone as well. If you've had a hysterectomy, you need just estrogen. If you're having symptoms affecting your sexual health in terms of coitus and your libido is reduced, then you would need some testosterone as well. Can we move to the next slide, please? And in terms of HRT, it really depends on what options you want. So HRT has, like I said, if you have a womb, you need your estrogen and progesterone. If you don't have a womb, it's just estrogen. So the routes of therapy, you've got the oral route, which can be the combined one or just estrogen alone. You've got transdermal. Transdermal means on the skin, which can be patches, which can be gel, which can be spray. In terms of the risk of side effects of HRT, the transdermal form of therapy has a reduced risk completely. If you need to have progesterone, you can have your progesterone as a coil, which is Mirena coil, whereby you can then have your Mirena coil stays in your room, and then you have the transdermal estrogen as patches or gel or cream. You can also have a vaginal ring, which we would use more so in women who have just local symptoms in the vagina. So they have dryness down below, or we talked about the atrophy of the vagina, whereby it's so dry down there, having sex can be painful. They can also have bleeding sometimes from down there. But if you have bleeding postmenopausal, please make sure you get seen urgently by your GP. Get seen by your GP, and your GP will refer you to the gynecologist, because any bleeding postmenopausal, you need to rule out uterine uterine cancer first before you assume it's due to the dryness of the vagina. Okay. The most common cause of bleeding postmenopausal is due to dryness of the vagina, atrophic vaginitis, but the most worrying is uterine cancer, so you need to make sure you see your GP when that happens. In terms of other routes of therapy, implants are hardly used nowadays. Next slide, please. So in terms of benefits of HRT, menopausal symptoms, helps with your menopausal symptoms, your hot flushes, your tiredness, your mood swings. In my case, I mean, I've said this many times, you get very ratty, you get irritable, and sometimes it's almost like you're unreasonable when you're going to an argument with everybody and anybody, and then you reflect on it a day later, you realize you're the one that's unreasonable. That's how I started HRT. Prior to that, I didn't want to start HRT. But when I realized that actually I walk through the door, everyone scampers in the home, my husband goes to one room, the kids go another room, and I start an argument. Well, I don't start an argument, they start an argument, but then it seems as if, with hindsight, I realized I was wrong. During the argument, everybody else is wrong. But with hindsight, I'm wrong. I had to go on HRT, and I can't tell you much more. It's the best thing I've done. So in terms of osteoporosis, also prevent osteoporosis, heart disease, we think that it reduces the risk of Alzheimer's. It's not conclusive yet. We think it reduces the risk of colorectal cancer, also not conclusive. But in terms of, there's been some studies that showed that it reduces, some studies showed reduced risk of colorectal cancer, some don't. Some studies have shown it reduced risk of type 2 diabetes. That's still ongoing, but we do know that when we talk about sarcopenia, which is reduction of body muscle mass and strength decrease, strength, as you get older, your muscle mass decreases, your strength decreases. We do know that HRT helps. And we know that when you have sarcopenia, there's increased risk of fall, which can affect your daily life, daily living. Next slide, please. So the talk of HRT will not be complete without talking about the risk, because that's what everybody worries about the most. Yes, there are risks, but everything does have risk. I say to people, crossing the road has risks. You can get knocked down, but you have to weigh and balance what you want to get across the road. What is more important? So in terms of risk, there is breast cancer. If you have a combined estrogen and progesterone, there is a small risk of breast cancer, but this is actually related to the duration of treatment, and the risk reduces when you stop the HRT. We also know that estrogen-only HRT is associated with little or no risk of breast cancer, estrogen only. So short-term estrogen use of HRT is unlikely to increase your risk of having invasive breast cancer. Studies have shown that. So in terms of estrogen-only HRT, we also know that transdermal, if you use transdermal HRT, i.e. your patches, your sprays, and your cream, the risk of breast cancer reduces with that. Also, transdermal reduces the risk of venous thrombosis as well, thromboembolism. With women with a higher BMI, we know the risk of thromboembolism is there. So we would recommend in women with that, they use transdermal HRT with Mirena or micronized progesterone. In terms of type 2 diabetes, there's no increased risk of developing type 2 diabetes with HRT. We know that with ovarian cancer, there's an absolute risk, which is thought to be 1 in 1,000 increased risk of ovarian cancer in women who use HRT, the combined one, over 5 years. We know that having hypertension, controlled hypertension, does not stop you from using HRT. With endometrial cancer, it's only unopposed HRT. What do I mean by that? If you have a woman, you take estrogen without progesterone, your risk of endometrial cancer increases, which is why we always insist on you having progesterone. Cervical cancer, there's no increased risk of increased risk of cervical cancer with HRT. In colorectal cancer as well, showed reduced risk of colorectal cancer in the combined estrogen and progesterone HRT, but there was no effect in just estrogen only. In terms of stroke, it's sort of conflicting studies. There've been a lot of studies and it's quite conflicting, but the risk of stroke is actually age-related, and the overall risk is lower in women under the age of 60. We know that estradiol, oral estrogen, has a slight increased risk of progesterone, and this is thought to be dose-related. We know transdermal estrogen is unlikely to increase the risk of thrombotic embolytic stroke, but in terms of hemorrhagic, it's not related at all. Next slide, please. Any questions? I hope I'm not confusing people. Are we good? So this slide is just sort of to summarize what I've been saying. If you have a womb, you have to have a combined one. If you've had a hysterectomy, estrogen only, could be oral, it could be transdermal. So if it's oral, you have the estradiol. If it's transdermal, you have the gel, the patch, and the spray. If you have your womb, it has to be combined, and it could be perimenopausal or postmenopausal. If you're perimenopausal, i.e. your periods haven't stopped, you have a sequential therapy, which can be oral or transdermal. If you've stopped your periods, we give you a continuous one so that you don't have any bleed while you're on HRT, which could be oral and also transdermal. Next, please. This talk will not be complete without testosterone. We all know testosterone contributes to libido, orgasm, and sexual arousal. We know that the levels of testosterone falls with age. Unfortunately, it's a male-dominated society out there. We don't have testosterone for women, but we use the one that's been formulated for men, and we sort of use it as part of HRT if it's needed. And this will be given to you off license. There are some that are licensed in the States, which are slowly coming in. Is that right, Nicola?
It's not licensed in the UK. It's licensed in America. It's licensed in Australia.
Okay.
It's licensed in Australia. So yeah, but there are private practitioners that prescribe testosterone off license here in the UK.
Yeah. Some NHS doctors also prescribe it as well, off license. As long as the woman accepts that it's off license, they can have it. And they usually do check your testosterone levels beforehand. And this is not so much as to see whether you've got a failure or not. It's more or less to have a baseline, and so that they can have an idea of whether the treatment is making a difference or not. And treatment usually takes about 8 to 12 weeks before you see any difference. Next, please. So alternatives to HRT, there are a lot of pharmacological alternatives depending on your symptoms. You've got antidepressants, you've got clonidine for HRT, for the hot flushes. Some people it works for, in my experience, very rarely does it work well. You've got gabapentin and pregabalin also for the hot flushes and also for mental health as well. Then you've got the non-hormonal vaginal therapies. What do I mean by that? The moisturizers, which helps with the dryness down below, and also for the lubricants. So alternative medicine, there's a lot of things out there. Alternative therapy, sorry. There are a lot of things out there. Holland and Barrett, they're great. I have no shares there, but they're very good and to advise you as to alternatives. So we've got St. John's wort, we've got soy isoflavones, we've got black cohosh, acupuncture. If you have a good therapist that can give you good acupuncture, it works. Cognitive behavioral therapy also works to help with the mental health bit of it. Yoga in the relaxation, homeopathy. Homeopathy as well works for some people. So flexology, that's all relaxation. Aromatherapy, I would recommend, and yoga. And that is the end of my talk. Thank you very much, everyone, for listening. If I've waffled a lot and I've sort of whizzed through very quickly, I apologize. I am so sorry, but I had less than an hour to do 2 talks.
It's been our pleasure to have you. At this point, we could take questions.
Okay, thanks, Falake. That was amazing. A lot of gems shared there, and I'll come in, when I talk, if I have anything else to add, I'll add that. Can we go to Alpa first, quickly, Alpa, with your question that you had from the first session?
Thank you very much. First of all, I'd like to thank Dr. Fulkami and the team for this presentation. It's been very, very useful. And as I mentioned in the chat, I'm one of those who suffer or is still suffering with the fibroids. And I'm awaiting the Sonato treatment. Hopefully that's a lifesaver for me. And yeah, I've had iron infusion because of the loss of blood that I've had. But either way, I know a couple of people had asked about diet. I was supposed to have the Sonato treatment a while ago, and because I'm type 2 diabetic, my diabetes was quite high, so I couldn't have it then. And I changed my diet, which meant I didn't have any rice at all, reduced wheat. It was mainly to control my diabetes. And I did do it. I brought my diabetes down a lot. But the other effect I had is my periods have got a bit better than what they were, because I've had like periods every 2 weeks with clots and clots and clots, and they've got better with my better diet, I think. I've never been a big alcohol drinker, but now I can't even drink any alcohol. That causes me joint aches even more. Even the occasional wine or anything, I can't drink that any longer. So yeah, what else was I going to say? I was going to say something else. I've forgotten now. Brain fog. But yeah, it's been really, really useful listening to this, and I use the HRT, which really helps. I think the gel works better for me with the progesterone. Because of the hot sweats. I was using the patches, and that just, I'm sure it's individual, but it's really hard with GPs to pursue all this HRT. I'm waiting for testosterone, but they've referred me to the hospital, and I've been waiting for like 4 months and I've still not got a referral. And yeah, so with GPs, you really have to pursue hard And it's just because I'm on a menopause group and I've heard other women talk about it. And hence this session's really important, because they've said, no, they've had to pursue, don't give up. And so I did the same. And that's how I got my HRT. So yeah, I would advise to other women, please do pursue with your GPs. Don't let them fob you off, because they do that. But yeah, thank you very much.
Thank you so much, Alpa. Thanks for sharing that experience. Thanks for the enlightenment. I'm going to skip quickly to the next question that I have here. Are there specific links between frequency and length of periods and fibroids and ovulation pains?
When you have fibroids, depending, like I said, depending on where they are, they can increase your bleeding. So you can have prolonged heavy bleeding, passing clocks. So before you know it, even if your cycle is still 28 days, you might be bleeding for 10 to 12, 14 days or even longer. So it seems like you're always every 2 weeks having a period. So that can be related. But does fibroid affect ovulation? No, it doesn't. The two entities completely. So you've got your ovaries doing his own thing quite all right, but the lining of the womb, which is where the fibroid is, that's where you could have prolonged period. And sometimes if you're becoming perimenopausal, I'm linking it to the other side now, your periods can become, your cycle can become very short or very long, and it could vary all over the place as well. So and it could be light 1 minute, heavy the next minute, long, clotting, and all over the place. I hope that helps.
Okay, I hope that was helpful for you. So next question, if someone is concerned about early menopause, how can they check?
Okay. Early menopause, the only way you can check, you can't check. Okay, that's it. So it's your symptoms. It's your symptoms.
Age
is what you
and your
present
symptoms,
with.
yeah.
It's your symptoms. There's no blood test that can confirm your early menopausal until you're menopausal, and that is you've had no period for 12 months. If anybody's doing your blood test while you're still having periods to check if you're perimenopausal, it's a waste of time, and it's just pain to you as well, because there isn't. The blood test that you can do, which is checking your FSH and LH, is 12 months after menopause. So it's your symptoms that you present with that could tell us if you're perimenopausal.
I hope that's helpful. So next one, what if you have induced menopause from tamoxifen? What would you recommend to combat weight gain, which seems to be unavoidable on tamoxifen?
Difficult. So to combat weight gain, I will go back to lifestyle. Mm-hmm. When I go back to lifestyle, I go back to diet. Mm-hmm. Alpa earlier talked about rice. Our diet is usually very high in rice, if we say, but that's carbohydrate. There's a lot of carbohydrate. A lot of people say, oh, I'm eating brown rice. Brown rice is good, don't get me wrong, because you've got the fiber, so the release, so it's low GI, so the release of your glucose is slow. So you have a plateau. Unlike if you have white rice, you have a spike. But the amount of calories and the carbohydrate content are similar. So what I say to people, first things first is the quantity. We eat a lot. I mean, if it's good food, I will eat a lot. So first things first, reduce your quantity, loads of vegetables, loads of nuts, loads of wheat, loads of grains, that's what we should be looking at. Reducing your carbohydrate intake, increasing your fiber. That would help with the weight loss. Exercise, exercise, exercise. I can't say that enough. We don't do much. People think by walking around in there at work is enough exercise. No, you need to do exercise that would increase your heart rate. That's exercise. Even if it's just walking every day, brisk walk, 30 minutes brisk walk, that would help as well.
I'll just add on as well, you know, Falake talked about the stretching and the strengthening. So if you're building muscle, that also helps with losing, getting rid of fat deposits as well. So again, but it's a combination. You've got to look at the diet, look at the exercise, look at the stressing and the strengthening, and just find out what works for you, and focus on something that will be sustainable rather than a fad, you know, because then if you build it into, it's called lifestyle, so that it's, you know, it's something that you enjoy, that you will, and you will see the weight drop. It's calories in, calories out. That's not to say count your calories or be, you know, but just be mindful. Portion control. There are various elements that can help with weight gain, or excuse me, I beg your pardon, with weight loss. Question, just this one is the final one around fibroids. At what point do having fibroids become concerning, and how frequent should you be checked by doctors if you have fibroids?
Okay, first things first. I think the first thing I said was that fibroids can be asymptomatic. You might have no symptoms whatsoever. So there's no reason to be checking them. None at all. The only time you check them is if you're symptomatic. And if you're symptomatic and that's being controlled, there's no reason to carry on having ultrasound scans. The only thing I would say, the caveat I would say to that is, if your symptoms change, so like your abdominal swelling all of a sudden seems to increase all of a sudden, you need to check, because there is a very rare complications of fibroid, which is it could become cancerous. Very, very rare, but does happen. And that's usually rapid growing mass, or all of a sudden your periods that wasn't too bad before has increased, or it seems to be much more. That's when you should have another ultrasound scan. Otherwise, it's not something that you need to be checking on it on a regular basis, except things are different.
That ends this question section.
Really? Thank you, everyone.
Thanks so much for being here.
Thank you. Very good. Yeah, thank you.
Thank you.
Introduce her. We're not done. Please don't leave yet. There's still another sort of 10 minutes. I didn't actually introduce her, but I'll allow her to introduce herself. She's been super helpful today in helping to facilitate. But she also has, especially from the NHS side of things, a 10-minute presentation to deliver. It might be a little bit less than 10, so I'll hand back over.
Hi everyone. Thanks for having me, Anthony. And obviously, you know, I'm a big fangirl of your work at Southwest London ICS and all of the. It's a pleasure to be here. My name is Buki Ayade. My role is menopause lead within the workforce training and education directorate here at NHS England, part of the National Menopause Programme here. And what I will be talking about is some of the interventions that we have created at NHS England to support our workforce. My background is pharmacy. I'm a pharmacist by profession. And what I will also say is I'm a postmenopausal woman. I'm in the trenches, supporting women to live healthy, live well, both here at NHS England and in beyond the NHS. Okay, so why menopause support at NHS England? We recognise as a responsible employer that we want to support our people at this phase of their lives. So women that are going through, and when I say women, I'm using women as an umbrella term. I recognise that not everyone that experiences menopause or has symptoms is of the gender is a cisgender woman, basically. So there are women, there are people of diverse gender expressions that experience menopause. So I just wanted to put that out there. So the organization wants to support its people. We know that 3 in 5 women will say that they are affected by their symptoms at work. We know that 1 in 10 will actually leave the workplace due to menopause. So not only being responsible, supporting our people so that they can stay at work, they can thrive at work, they can stay as part of the economy, stay to look after the brilliant organization that is the National Health Service, but it is also a retention issue. So the menopause program within the Workforce Training and Education Directorate sits under the retention program. I've just popped on there some of our NHS numbers. We typically, before, we were looking at ages 45 to 55, but we've actually spread that into 40 to 55, recognizing that some ethnicities experience menopause earlier. And if we look at our NHS numbers, all staff at that age range, you would see that a significant proportion will be impacted by the menopause at any point in time. We extrapolate the 1 in 10 of that proportion, that's significant numbers that we cannot afford to lose. So we need to ensure that people affected, line managers, they have the resources, they have the support, so that our people stay well, and they thrive whilst at work. Next slide, please. So what have we done so far? I'll just skip through these items. Number one, we've created a guide that supports line managers, because as of October 2021, it was possible to report menopause-related absence on ESR. So, so that what that does is, you know, within your units, within your organizations, you're beginning to capture the data so that you can then begin, and that data informs the support that you need. It informs your workforce demographics, etc., etc. So that guide does exist, and when I finish, I've copied and pasted all of these links. I'll pop them in the chat for you. So that's one of the things that's available for line managers. They understand it, and then they can talk to their staff about how, you know, when there's sickness reports, you can use the right coding. We then, in June 2022, signed the Wellbeing of Women Workforce Menopause Pledge, which demonstrates NHS England commitment. Thank you, Anthony. Which demonstrates NHS England commitment to being a menopause supportive employer. So that pledge, I can share where we've signed that, and if, as organisations, if you want to follow suit, it's quite simple. I've just completed a little crib sheet that tells organisations how you can do that yourselves, and and once you sign the pledge, you're able to use the logo to demonstrate that, and you know, it shows that when people are looking to organizations to come in, it's used, can be used from a retention perspective, but can also be used from a recruitment perspective. We then have launched a couple of, in November 22, we launched national guidance, and I'll talk about the national guidance document in that it is a big document. However, we know that our people are busy people, so it's hyperlinked so that you can just jump to the section that you need. So a couple of things that I would say are useful on there are, within the appendices, it talks about understanding your data within an organization as it relates to menopause. It talks about how to have well-being conversations as a manager to support your colleagues or women, people going through experiencing symptoms. It also talks about reasonable adjustments. What is it we can be doing to support our women? I talked about people of different diverse gender expressions. That guidance has a section that talks about our transgender and other communities, and also within the appendix and resource area, that so you can what I would say is just familiarize yourself with the headlines of the guidance document, and when you need something, just go there, find it quickly, and use that. We also launched the self-care fact sheet. The self-care fact sheet is it's like a little crib sheet that's quite useful. It's useful for both women, but it's also useful for clinicians because it was drawn up with the Self-Care Forum by our clinical reference group, who is the good and the great in the menopause world. They sit within the so it's a body of about 44 clinicians, and I mean, if you know, to get something like that approved via them is quite is no mean feat. So I'd suggest, you know, familiarize yourself with that self-care fact sheet. We have also launched 2 e-learning modules. One is a core menopause module that's available to our NHS workforce. Just gives you the nuts and bolts to know, you know, to a lot of what Folake talked about just now, but also it's a module that's it's got a lot of graphics. It's quite interactive. Won't take you too long, but it's a good investment in time for yourself and to help support others as well. Off the back of that, in September just gone, we launched a specific module that's nuanced for occupational health, our occupational health colleagues, recognizing their importance in supporting well-being in the workplace. So it was co-produced with a core group of occupational health clinicians, and yes, that was launched at their conference in September. What we also did was collaborated with our health and well-being colleagues. So we thought, okay, we're not going to reinvent the wheel and create menopause champions, but we collaborated with our health and well-being colleagues and upskilled our existing well-being champions and ran a series of developmental sessions with them from October and they just finished in March of this year, obviously from a budgetary perspective, but we're looking to pick something up going forward with them. The recordings of all of these sessions are available. They've just been uploaded to a future site, which I'm going to launch imminently. I just need to conclude on its location, and I'll push that out to Anthony and he can share that. Well, what I would say is a lot of these resources that we're creating nationally are so that you don't have to do the work yourselves. Go there and pinch and steal and share and use with pride. Just use them. You know, if you're looking for something that you can't find, by all means let me know. As I said, on the future site, we're looking to create, we've got all of these will be there, but there are various other resources. We're going to create best practice case studies of organizations that are doing good work, so that if you're looking to support your organization, do anything in your organization and thinking, where do I start? There'll be, and then there are various other guides coming through as well. I have no more time, so I shall pause there. That's where you can access all our resources, and I'll pop these links in the chat as well.
Thank you so much, so much. Also, what I will do is I will put a link to the health and wellbeing leads at the various trusts as well on the staff support website. So if you do want to join a menopause community, put yourself on the mailing list, find out what offers we have, then please, by all means, get in contact with the health and wellbeing lead at your trust. And yeah, they'll be able to get that information to you. Very big thank you to Dr. Folakemi. Very big thank you to Bukayode. Thank you so much for facilitating the session for us. As I said, it has been recorded. Saying that, I will stop the recording now. And yes, this will be made available for the staff members that didn't attend. So if there's anyone that you know that wanted to attend and couldn't, then yeah, they won't miss out.